Joining me in this Tell Me More About session is Itsvan Urban from Hungary. Itsvan, welcome.
Thank you so much.
You did a session here in the Monaco Congress earlier today where you talked about vertical bone augmentation and delayed implant placement, a very relevant topic in this theme of timing in implant dentistry. What is the latest scientific insight that you brought to our audience?
Well, number one, I dived into some of the new research, which is mainly preclinical first, about the importance of the communication of the graft and potential growth factors with the overlying soft tissues and the periosteum.
Let me see if I get that. So the communication of the graft with the overlaying tissue.
Potential growth factor to the overlying tissue, yeah.
And what did you dive into? What did you find?
So we looked at like a completely occlusive device. Then when you have the blood clot and you're in the surface of the bone and you have something in there, or you have a device that has certain size of opening, and we want that size to be communicative but not soft tissue ingrowth. We can talk about that too. So then you have a graft that can communicate with the blood clot, with the surface of the bone and the overlying soft tissues. So we looked at that. Mm-hmm. And we found that, so first we wanted to understand that these mesenchymal cells outside in the soft tissue, how important they are. And so we started to stimulate any mesenchymal cells and used a growth factor, the BMP2. And so in the occlusive area, they can communicate with the blood clot and the bone. Mm-hmm. In the perforated area, they can communicate with the bone, the blood clot, and the soft tissue. And now indirectly, from the result, we can tell how important the soft tissue was. It looks like it was very, very important.
So you say the soft tissue or the connection with the soft tissue has an effect on the growth of bone.
Exactly.
How can that be? Were you able to determine that?
Yes. So because in the soft tissue, like the periosteum has two layers. One is the cambium layer and the outer layer is the fibrous layer. Membranes were developed to exclude cells, mm-hmm. which are in the fibrous layer, fibroblasts. But in the cambium layer, which is closer to your bone graft, there are blood vessels. Blood vessels, we know they're important for bone regeneration, and there are progenitor cells. And we know that progenitor cells, if somebody tells like a growth factor can tell progenitor cell, okay, well, you know what, you become a bone cell. Mm-hmm. And then they become a bone cell, and that would help.
Yeah.
And so, but we don't know exactly how important they are. Is there a potential? Are they talking to us for the last 30 years? Hey, we want to help, but you guys
but you excluded us. Yeah. What type of magnitude of effect do you see when you say improve?
Gigantic. I mean, it's like crazy. It's like
define crazy.
Crazy is like we figured out that there's not in the blood clot. There's like no mesenchymal cells. I mean, this poor growth factor, which is very expensive, and only communicating with these progenitor cells, didn't find anybody. Okay, so under the membrane there was no bone. Mm-hmm. From the bone, there's some apposition of bone that's like very slowly growing up. Yeah. So a big gap. But then this device is not perfect. So probably some growth factor was seeping out, touching the bone graft, touching the soft tissue, and above the membrane there was bone. There was bone above the membrane, there was no bone under the membrane. So, and the perforated device, there was bone all over the place. We could barely find the membrane.
Was this specific for the device or the membrane used in this study, or is this a generic phenomenon you see when there's membrane used?
This is a biological principle, mm-hmm. okay, which we obviously exaggerated because we use something that can only communicate with mesenchymal cells. So this study shows the importance of mesenchymal cells. And then I also looked at the next study we did. Yeah. Based on this, we said, look, okay, so that means that maybe when we do a bone graft and there's some growth factors that we put, or there's some growth factors inside the bone graft, then maybe the location is important. Of the growth factors, exactly. Or the biological factors.
Whether they are close to the bone or close to the soft tissue.
Whether in the middle bone or soft tissue. So we, again, use a microdose of a growth factor, but again, not because of the growth factor, because of to see if I put something which has an effect on mesenchymal cell. Mm-hmm. So we chose this because we know that this has a perfect effect. And we started to position it in the middle of the graft. We called it the sandwich.
Yeah, of course.
Okay?
Yeah.
And we put it outside, just like a graft which has no biological effect, just a simple xenograft which has just a stabilizing effect for the growth for the blood clot. So when we put it outside, we call it a lasagna.
Yeah. Okay.
Okay,
yeah. It's easy. You need to make science communicable.
Yeah,
right? So
I prefer
we
lasagna over a sandwich.
We have the lasagna, yeah.
And then we had two, control groups.
Yeah.
And what we found is exactly what we predicted. Number one, we use a very, very small dose, so like a microdose. Mm-hmm. And what we found that when we put it in the middle, many of the samples had no bone in the middle. There was a big void. But then some growth factors came out because now we used the perforated one.
Yeah.
Touched the soft tissue. So above the membrane, there was perfect bone. Below, again, a void. When we did the lasagna, which was directly communicating those cells which we're talking about, talking to us for 30 years, and they performed not bone only on the top, but the entire graft became bone.
The entire graft, all the way to the original bone level.
Yeah, and we waited on for 2 months only in these animals, which is like they're healing faster.
That was my next question. This is an animal, because I was wondering how many cases were you able to do this? I like it, control group, everything, but this is difficult in real patients, right?
It's difficult in your patients.
So this is an animal study.
It's an animal study, but it's not so difficult in your patients because, for example, in North America, this is on the market.
Mm-hmm. Now you talk about the specific growth factor?
A specific growth factor. And in the European Union, it's on the market, but for different indications, for neurosurgery and things like that. And we have submitted ethical approval with Professor Windisch, a good friend of mine, the two of us, to do a randomized clinical trial to repeat the lasagna effect on the vertical ridge augmentation. So I actually, in my lecture, I showed this is a biological phenomenon.
Yeah.
And then I showed cases when we used microdose of this device, and we created we had patients who were it's very difficult, like patient who had lost the mandible and had entirely, and they had like a fibula, like this little bone, transplanted in here with fat and all that. And usually put a bone graft on it, they don't work very well. Mm-hmm. So what we did, poor host, we did a bone graft, lasagna, stimulated the overlying soft tissue, and got perfect bone. See, it looks like it's going to work very well on humans, but it was one of the insights that in terms of biologically. And
does it mean, that I understand correctly, this case, for example, you have to do in the Americas?
You have to do it in America, or it depends which country you do. Like in America, it's off-label. You do it because it's, like the FDA, there's different indications. Okay, let me give you one example what is like off-label. Off-label would be like you use, there is a medication called Tegretol, Swiss medication. It's all over the world. It's very good for neurotic pain. Mm-hmm. It's also very good for epilepsy.
Okay.
In some countries, you open it, it's licensed for neuropathic pain. But what if you have a patient, this would be the perfect medication for epilepsy? It's not illegal to use, but it's off-label to use.
Gotcha.
Okay?
Gotcha.
So, but usually what they do, then in those countries, they register it for that indication.
Yeah.
Okay, now in the European Union, it's registered for neuro and all that. So microdose you could use off-label. But it's off-label everywhere so far. I think but the next BMP will come in, and I don't want to talk about BMP, but next BMP will come in, hopefully, with another BMP, I think it's BMP 7 or BMP 5 or 5. Anyway, so it's going to be licensed, hopefully everywhere.
Itsvan, would you say if all limits are off, so it's FDA or it's ethically approved, all licensors are on green, this would be the new standard of care? Would you always do a vertebral bone augmentation like this?
Let's wait for the
This
study.
is interesting. You doubt. Why the doubt?
No. Because I only will say yes once you have a randomized clinical trial.
Yeah. Okay. So the scientist in you is still a bit cautious.
I would be extremely surprised if not.
Yeah, I can imagine.
Because you can do a microdose. You need a microdose, which would cost like 200 euros. Okay. So, I mean, the results, what we see is much better.
Based on what you've seen now, would this work in any area where you want to do a vertical augmentation, or are some areas better fit than others?
I would say anywhere.
No restrictions on that.
But again, low dose.
Yeah.
Not to have a lot of swelling, and just improve the healing.
Exactly. Any other takeaways from your session on stage today?
I mean, this was not my main takeaway. Was not even this. My main takeaway was
this was just the news, right? This is the news.
Exactly.
Yeah.
It was what do you do when you have cases, young patients, who had previous problems? Like imagine somebody who had implants failed. They removed the implant and somehow the canal got exposed. Mm-hmm. There's a big defect, canal is exposed. Or the mental nerve is almost on the crest. So we have a very short flap. You have scar tissue. You have to put in a much bigger bone graft and close it with a flap that is this short down. How do you do that without damaging the nerve? That was one of my topic. And
you got my curiosity, Itsvan. How do you do that without damaging the nerve?
So, because let's imagine you have a 4 millimeter flap.
Mm-hmm.
How do you advance a 4 millimeter flap to 20 millimeters without damaging the nerve? Because nerve is right there. Well, I wish I could tell this to myself 20 years ago.
Well, tell us now.
But now I can tell.
Yeah.
So basically, you go through only the periosteum. You cannot cut deep because the nerve is right there. Mm-hmm. And you have a very short flap. You want vascularization of the flap. That means you go very close to the mental foramen. So you cut on top of the nerve. Mm-hmm. And once you cut on top of the nerve, I put in on the other side a bite block to make sure the patient's not chewing on it or closing immediately when I'm doing that. Yeah. Then I cut on the periosteum. Then after I cut the periosteum, then I have a blunt instrument that I very carefully start to stretch the flap. But I can stretch only 2-3 millimeters.
I was going to say, you're still not far away from 20, yeah?
Okay. Under the periosteum, usually there's little collagen fibers, little bundles that we debundle, that we rotate the blade and we say we play the guitar on those strings. Dong, dong, dong. And then stretch 2-3 millimeters. Then what we do is called a gradual stretch. We stay patient. So we stretch 2-3 millimeters, debundle, 2-3 millimeter, debundle. And once in these 2-3 millimeter segments, we bypass the entire nerve. And that's when we start to pull a little bit more force. And the whole thing is like beautifully coming up. You may see through the nerve, but the nerve is completely intact. You see the fiber, the big branches of the nerve, and now you have a long flap. Plus, you have the lingual flap that I also talked about. You have the 3 zones and how you advance the lingual flap, and then you can close these flaps. All of a sudden, and this young patient who's 45 years old is going to have
a good restoration. Yeah, and bone again. However, Itsvan, I've seen you many times in these congresses. You are a very, very experienced surgeon. I can imagine this is not for everyone, right?
I think this can be for everyone.
As a concept, the stretching?
Who is serious about this, who wants to learn, okay? You have to be very serious about this.
Because you're super close to the nerve.
But it's not about, how talented I think. It's, I think, how serious you are. And then how dedicated you are in terms of, okay, let's go through this, okay? And we have published an article, but I want to publish a decision tree, okay? I have a patient, short flap, long flap, okay?
Decision 1.
Okay, then native tissue, fibrotic tissue, scar tissue, okay? Worst would be very short flap and scar tissue, okay? What are the little details you have to do? So first you make a diagnosis in your mind. I'm going to have this patient had 5 bone grafts, a lot of scar tissue. This patient has super short flap. Before I'm going to get a heart attack, I have to make a decision what I'm going to do. Okay.
Yeah. So what are the alternatives, except not treating?
Okay, you could put an extra short implant in some of them, but what I showed you can't.
Okay.
Because they were very narrow and it was like 1 or 2 millimeters from the nerve. And imagine a 45-year-old patient who's coming to my practice. I'm looking at it. The nerve is exposed. It's like, do I need this? Do I really want to do it? I want to do it.
You mean yourself as a professional?
Yeah, but do I really need it? The patient's looking at me. Yeah, of course I want to do it.
Yeah.
And so somebody has to do it. But I think, and again, so if you have this decision tree in your mind, you have the training, you're dedicated. Okay, let's say I have a short flap, native tissue. This is what I'm going to do, what I just explained.
Yeah.
Okay, and you sit down like that. It's different.
And it sounds like the room for error is zero.
For this particular, but it's an extreme example. There's not much of a room. But you're not going to make for error. You're not going to make an error because you know exactly what you're going to do. And when you mentally prepare yourself, this is what I'm going to do, or you just go into a surgeon, let's see what happens, and I'm going to. That's not working.
Different attitude. I don't know if there's any surgeons out there who approach your surgery like that, but
no. But if you have no idea, don't do it.
Yeah. Great example. So that's something you also shared in your session. But what is the key takeaway? What do you hope people take into the clinic tomorrow morning?
I think that number one, patient preparation is very important. So everything has to be super clean when you do surgery. How you approach a flap design and a flap advancement is very important. And we talked about the anterior maxilla. Mm-hmm. How important that is that you do it as a comprehensive. That comprehensively looking at it, that means that you have a defect. Usually it comes with a soft tissue defect. Mm-hmm. What are you going to do with it? How is that going to look? So how much time is going to take? And because once you start to do it, you have to go from A to Z.
Yeah. There's no way back.
There's like in the middle, you say, oh, this was good enough. Okay, that's good enough for you. No. You have to go until Z.
Yeah.
Okay, or don't start.
Yeah. So planning is key. Patient selection. Any other thing you hope people do more carefully or take away from your session?
Patient preparation.
What does that mean in your
Patient
world?
preparation means like that I see that they do, let's say somebody's doing a bone graft and the neighboring tooth has a crown with an open margin like this. Mm-hmm. Why? Oh, patient didn't want to change it. No, but now you have an open margin. You know what's in there? Bacteria. Mm-hmm. You know why do you have pus and an infection? Because that you suture the flap up under the margin and now it is infection. You do this beautiful surgery for nothing.
Yeah.
So before you do this beautiful surgery that you learned, you have to prepare the patient for it. Has to be, if that crown is not good, change the crown.
Yeah. So that's why you don't use the word selection, but preparation. Yeah.
Preparation.
So that might mean you first go to work at the adjacent teeth in order to have a site.
To clean everything, treat periodontal disease, so have a mouth that is really ready for you to do bone.
Do you feel that's often overlooked?
I think it's very often overlooked.
Yeah.
Very often overlooked.
Too much focus just on the implant.
Hey, oh my God, this is what I'm going to do. And then it's like, okay, but you didn't prepare the patient. So patient preparation. And then, of course, you have to learn this. Mm-hmm. Once you learned it, and you prepare the patient, of course, very important, the postoperative management, provisionalization. So there's a lot of little things. But I think the two most, seriously, the most overlooked is the preparation for the patient.
Exactly.
And then the surgery.
Interesting, very interesting findings. Thanks for your passionate sharing of those. And it was an honor to talking with you about this. Thank you for being here with us.
Thank you so much for having me.
And thank you for watching this episode all the way to the end. I can imagine you get excited, you want to learn more. Make sure you check out all the other episodes of Tell Me More About and all the other educational scientific content here at Monaco Online.